Hello, how are you? Welcome all of you to the City and Industrial Development Corporation (CIDCO), which was formed on 17th March 1971, and that is Navi Mumbai. It was designed by CIDCO, and it is just next door neighbor of Mumbai. We have South Navi Mumbai and North Navi Mumbai, and it is basically a new Mumbai, and we have wonderful skyscrapers, Palm Beach, Vashi, and it's an area from Kharghar to Uran. And today we meet the doyens of Navi Mumbai. Navi Mumbai society has a very wonderful, illustrious history. It basically was few number of gynecologists in the year 1996. They came together and formed their own association. And we had that time Dr. Pradeep Kokkar, Dr. Pratibha Utge, Uday Thanawala, Vishnu Agarwal, Sureka Mude were instrumental. And as this association grew and further, it was merged with Foxy when Dr. Mandakini Pariyar came into action. Sadly, she is no longer with us. But in the year 2006, Navi Mumbai Obstetric Gynaec Association matured into Navi Mumbai Obstetric Gynaec Society, and since 1993, they have been having annual conferences every year, and they have wonderful orations, namely NMOGS oration, Dr. Pradeep Kokkar oration, and we have Dr. Shirish Daftari oration. So this is what is Navi Mumbai, and I would like to thank Bharat Serum and Vaccines, Science Integra, and the program of Bridging Bharat to get this RPL webinar from Navi Mumbai live. Your host, Dr. Niranjan Chavan. Thank you so much. My next door neighbor, and I welcome the past president, Dr. Bharti More. She is a postgraduate from my own Sion Hospital, that is Lokmanya Tilak Municipal Medical College. She has been practicing in Navi Mumbai since 1990, honorary gynecologist at Mathadi Hospital, and she was the president of IMS also in 2015-18, has worked in Foxy Oncology Committee, Medical Disorders and Adolescent Health Committee, and today she is going to talk on recurrent pregnancy loss. Welcome, Dr. Bharti More, madam. Thank you. Dr. Uday Thanawala, the doyen of gynecologists in Navi Mumbai. We all know him. He is the most handsome guy in this part of India. Consultant obstetrician and gynecologist in Navi Mumbai, vice chairman of ICOG in 2018, and he is also the chairman elect in 2021. He was also the president of Navi Mumbai Society, and his field of interest is ultrasonography, maternal medicine, fetal medicine, high-risk pregnancy, a gold medalist in FCPS exam, Dr. D.K. Datta Award, Sir G.M. Masani. Thank you so much, Uday Thanawala. Thank you so much.
Thank you very much, Niranjan. And I must thank Shashan here for that wonderful video of Navi Mumbai. And thank you for putting Navi Mumbai on a map of Foxy webinars. So people all around have had a look how beautiful our city is. And it's a little uncluttered and a little different from the regular Bombay. But it is very much a lovely city, and I'm glad I'm here. And thank you so much for bringing it up today.
Thank you, Uday. Now you're grown up. Now you're grown and you're the most nice. Thank you so much. Today we are getting this thing done after 15 days of working together. Thank you, Uday. And we come to the president-elect of Navi Mumbai, Dr. Rahul Vani. He is going to be with us. Along with him, we will have Dr. Bindu. He is a consultant at Mathadi Hospital. He is associate medico-legal consultant, member of the Ethics and Medico-Legal Committee, Foxy. and also a lead assessor of Manyata project. Dr. Rahul, welcome.
Thank you for the introduction.
Now we will have Dr. Bindu. She is the present secretary of Navi Mumbai Obstetric Gynec Society. She is a consultant at Apollo Hospital, and we are very happy that she is going to be also one of the panelists. And this whole program has been thankfully done because of the president, Mini. Dr. Mini is going to join with us very soon. So it is a wonderful way of having this program with us. Thank you so much. And we go ahead with the first presentation of Dr. Bharti More. Please unmute your mic, and we will be sharing your screen. And the topic today is going to be recurrent pregnancy loss. Please unmute your mic.
Hello.
Yes, we can hear, madam, very nicely. Please go ahead. You need to share your screen with a green button there, and then your presentation will start, and we will all be enjoying that presentation. Yes, we can see.
Okay. Yeah. At the outset, I would like to thank the Foxy, especially Dr. Gandhi and Dr. Tang, especially Dr. Niranjan, for giving us, especially the Navi Mumbai Society, the opportunity to take part in this webinar. And thanks Science Integra. The objective of today's talk is identify what are the possible causes of early pregnancy loss, outline the basic evaluation for recurrent pregnancy loss, and review whatever we can do the current treatment approaches for the same. So start with definition. Classically, 3 or more consecutive pregnancy losses before 20 weeks, but nowadays as 2 or more consecutive losses, we consider that it is a recurrent pregnancy loss. Even the ASRM is giving the same definition. But as you see that evaluation should start after 2 losses based on the patient's age and the desire. We see that 5% of the couples attempting pregnancy have 2 or more consecutive losses. 1% have 3 or more consecutive losses. But most clinicians consider RPL even if losses are not consecutive when they are 2 or more. We can see that 34% of pregnancy loss is seen in a prospective cohort of healthy women. Out of that, 22% are unrecognized, that is a biochemical pregnancy with biochemical loss. 12% are clinically recognized. And if you ask the obstetrical history, you will see that if there's a prior loss, there are 19 to 24% chances of a further loss. And if there's a prior success, there are 4 to 6% chances of the loss. And a single loss, if it is there, it definitely increases the risk for the next pregnancy unless there's a successful pregnancy intervening. Nowadays, distinction between sporadic and recurrent has lost the difference. And the effect of maternal age is very much important. You will see that 50% by the age of 40, both aneuploidy and euploidy, you will see that there are losses. Here is a diagram showing that depending on prior losses, the recurrence rate, as you see that initially if there's one live bond, then there are only 24% chances but of recurrence. And the losses, I'm sorry, the prior losses, if it is 0, then there is 12% chance. But you see, when it is increasing, that is from 0 to it goes to 4, the increase of recurrence is 12 to 26. On the other hand, you will see that if there are no live births, then definitely if there are 4 prior losses, then it goes to 54%. The take-home message is the number of prior losses more are the chances of recurrence risk. You can see that the pregnancy loss is increased with PCOS whenever there is increased LH, increased DHAS or testosterone. And definitely when these patients are treated with GnRH agonists, you will see that the rate of miscarriage is low. And even when they're treated with insulin resistance is taken care by giving oral anti-diabetics like metformin, you will see that the incidence of abortion is very less. So you can see that 10 to 15%, the recurrent pregnancy loss, the causes are congenital anomaly, but variation of other factors can also be seen. That is congenital anomaly of the uterus. We have a double uterus. Septate uterus, the rate is 25 to 90%. Bicornuate uterus, it is 40%. Unicornuate uteri, 50% is a loss. Uterine diadelphi. So whenever you think about recurrent pregnancy loss, you have to consider what are the causes. Now the causes can be divided into the following. That is, one is the anatomic factors, which I am discussing right away, which accounts for almost 10 to 15%. Then 2 to 5% are genetic causes, where it is responsible for the early abortions. 0.5 to 5% is infections. 10 to 20% are the endocrine causes, where you have the PCOS, the leading. You have diabetes mellitus uncontrolled and hypo or hyperthyroidism. And 10 to 15% are anatomic, 20% are autoimmune. So despite of that, you can see that the 40 to 50% of the cases, they are unexplained. And therefore, because of that, it becomes very difficult for us to really pinpoint what could be the cause for the successful pregnancy. The most important dilemma of RPL is that, first of all, even if there is a spontaneous abortion, there are chances that the next pregnancy will be successful. Then there is lack of consistent definition for RPL. Then limited access to the product of conception for the study further, for the histopath, and remarkable good prognosis for a successful live birth despite of previous losses. So these are the incidences which are seen. 10 to 15% have first trimester loss when there is a congenital anomaly. In that, it could be a double uterus, septate uterus, bicornuate uterus, unicornuate 50% loss, diadelphi 40%, intrauterine DE exposure because of the abnormality in the uterus. Cervical incompetence also comes here, and intrauterine synecdoche, which is mostly post MTP, or it could be because of infections or tuberculosis, which is very common in India. Unclear relationship between uterine leiomyomata is seen, but definitely a submucosal fibroid distorts the cavity, occupies a large subendometrial area, and therefore it could be by mechanical constriction or by inadequate placentation resulting from poorly vascularized endometrium. These are a few pictures for the same. Infections. Certain infections are seen, that is colonization with uroplasma uroleticum, and very rarely rubella, HSV, CMV, measles, and Coxsackie. Toxoplasma gonorrhea also can be one of the cause. But the other factors which are responsible, you can see that, as I spoke, that genetic factors are 2 to 5%, trisomy, monosomy, that is 45 external syndrome, triploidy, tetraploidy, and mosaicism. They are the ones which are responsible for the first trimester losses. Parental abnormalities, 3 to 5% of couples with recurrent loss. Balance translocation, most common, 60% you see reciprocal, or they could be Robertsonian translocations also. But eventually they may produce normal offspring. There's speculation about the single gene mutation, that is blastocyst formation, implantation, and morphogenesis of the vital organ. You can see skewed X inactivation, which is seen preferential inactivation of one of the X alleles, lethal to a male offspring, and may result in X autosome translocations, trisomy, mosaicism in the germline. Advanced maternal age, impact of pregnancy loss, you can see it is because of the number of oocytes they reduce, and the quality of the oocytes, it goes bad, and that is why you have more losses as the age of pregnancy goes high. Now, pregnancy is a hypocoagulable state, and therefore women with heritable or acquired thromboembolic disorders have significantly increased risk of pregnancy loss. Here I could just divide them into two. It could be either congenital or it could be acquired. Now, in congenital, you can have hyperhomocystinemia, activated protein C resistance due to factor V laden mutations, protein C and protein S deficiency, prothrombin promoter mutations, and antithrombin mutations. Acquired, you have again hyperhomocystinemia and activated protein C resistance. The most common inherited is heterozygous factor V laden, Factor 2, that is prothrombin mutation, and hyperhomocystinemia, which is seen as MTHFR, that is methyl tetrahydrofolate reductase. It gets reduced in the two of the following situations. That is C677T and the A1298C, which is why there is a reduction in the MTHFR, and therefore there is hyperhomocystinemia and there is reduced folate in the body. The most common acquired is the antiphospholipid antibody, that's the APLA, where you have activated protein C resistance. Then there is, of course, is hyperhomocystinemia. Other possible abnormalities could be antithrombin deficiency, protein C or protein S deficiency, and elevated factor 8. Hyperhomocystinemia, APS, and lupus anticoagulant are the most common. If factor 5 laden, you have abnormal factor 5 resistant to anticoagulant effects of activated protein C. Majority of the patient resistant to activated protein C will be heterozygous for the factor. So it is seen in 3 to 8% of the white population, rarely seen in blacks, Asians, and Native Americans. Autosomal dominant, it is acquired activated protein C resistance, especially seen more if there's a oral contraceptive pill used for a long time and if there is a APA also present. Heterozygous, it is 7 times increased lifetime risk of thrombosis and 15 times increase if it is a 15 times increase in pregnancy if OCP is used. If it is homozygous, then you see that there's 50 to 100% times increase lifetime risk thrombosis. So these two are very important conditions that one has to bear in mind, and then therefore the role of lower molecular weight heparin, which Dr. Uday is going to talk very shortly on. You have prothrombin.
Aarti, can you just lift your laptop or the mobile little showing your face? Yeah, that would be better. Thank you so much.
Can you see me? Can you see me? Okay.
Yeah.
Okay. Okay.
Or you can keep in front parallel to your face rather than just for only 5-10 minutes are remaining. That's fine.
Yeah. So am I audible now? But
yeah, you are very good audible. Don't worry about the audio, but just see that the face is seen. Thank you.
Okay. Yeah. Am I seen now?
Yes, madam.
Okay. So prothrombin G2021 2210A mutation. Here you see higher plasma prothrombin concentration.
Madam, you are unmuted. Please.
Yeah.
Continue.
So, recent critical review suggests an association definitely between the hyperhomocystinemia polymorphism, which is either heterozygous or homozygous, and it is seen more in whites. Hyperhomocystinemia polymorphisms are seen 33% in Dutch population also, where you see that the plasma folate levels decrease. So, a significant association between hyperhomocystinemia and RPL. What is the mechanism? Interference in embryonic development through defective chorionic villus vascularization. No association with later pregnancy-related complications. Antithrombin D deficiency, you can see that it's a physiologic inhibitor of coagulation. So, it could be type 1, that is quantitative, that is decreased antigen and function caused by gene deletions, nucleotide changes. It could be type 2, which is qualitative, where the normal antigen levels are there, but decreased function. This is caused by point mutations with single amino acid changes leading to a dysfunctional protein. Antithrombin deficiency, autosomal dominant, type 1 heterozygous, 1 in 2000 to 1 in 5000. Type 2 is again the prevalence is type 2 heterozygous, which is 3 in 1000. So most thrombogenic is inherited thrombophilia, 20 to 50% lifetime associated, increased risk stillbirth and fetal loss. Protein C deficiency downregulates coagulation cascade. Deficiencies lead to unregulated fibrin formation. Autosomal dominant, more than 160 mutations. Type 1 quantitative and type 2 is decreased function associated with second trimester loss. Protein S deficiency, principal cofactor of activated protein C. Mimic C deficiency, there is association with pregnancy loss. Autosomal dominant, and the prevalence is 0.15 to 0.8% in general population. Acquired forms in multiple disease states. Again, it can be type 1, which is quantitative, and type 2 is decreased function. Type 3, you can see low free protein, normal antigen, and reduced activity. Then is a luteal phase defect, which is discussed. Luteal phase defect, studies provoking LPD as a cause of RPL. In this, what they say is, as there is a lag more than 2 days between the histopathological changes and the day of menstruation. So there is a dyssynchrony between the maturation of the egg and the formation of the endometrium, and therefore there are implantation failures, and therefore the role of progesterone. Now there's poorly controlled diabetes, overt hypothyroidism, and other causes, that is metabolic disorders, which could be responsible. Certain autoimmune diseases which are associated with pregnancy, you have systemic lupus erythematosus. First trimester loss is almost 10%. Second and third trimester losses are 6%. Antiphospholipid antibody syndrome, second trimester loss is almost 38%. This is the one which we see very commonly in our day-to-day practice. Antiphospholipid antibodies, these are autoantibodies recognizing various combinations of phospholipid binding proteins or both. APL is clinical association between APL and syndrome of hypercoagulability. So the diagnostic criteria, you have clinical features and you have laboratory features. Clinical features, vascular thrombosis or loss of fetus at or after 10 weeks, preterm delivery at or before 34 weeks, or 3 or more consecutive spontaneous abortions before 10 weeks. APS laboratory diagnosis, anticardiolipin antibodies, IgG or IgM at moderate or high level on 2 or more occasions at least 6 weeks apart. Lupus anticoagulant antibodies detected on 2 or more occasions at least 6 weeks apart. Other antiphospholipid antibodies, you have anti-phosphatidylserine, nearly always associated with APS, highly correlated to cardiolipin binding, and other antibodies have less correlation. Lower levels of APL, they are not associated with recurrent pregnancy loss. Assays of a non-ACL APL are not standardized. Studies sometimes therefore are contradictory, but as a clinician, I would always suggest that day-to-day practice, you will see that, the books and practice, they don't go hand in hand always. So other autoantibodies which are not associated with RPL are antinuclear antibodies, antithyroglobulin and antithyroid peroxidase. These are the markers. If increased risk, they have the markers which have increased risk for pregnancy loss if identified early in pregnancy. Some small studies suggest a slight association with RPL. Other large studies say no. So again, there is a controversy over this. Immune response to non-self components of pregnancy, where the fetus is sort of a graft and the mother is the host. So normally cytotoxic antibodies, absence of maternal blocking antibodies, and if there are inappropriate sharing of HLA, disturbances in natural killer cell function and distribution, then the host considers the fetus as a outsider, as a foreign body, and if they don't work properly, then it is thrown out as recurrent pregnancy loss. So maternal response to paternal antigens present in normal pregnancies, more common in fertile couples than those with RPL, but there is no bearing on subsequent pregnancy outcome. So blocking antibodies, what is the theory? Maternal anti-fetal antibodies block the maternal cell-mediated response, and if this is absent, then there is a fetal rejection which occurs. So blocking antibodies not present in normal pregnancies, yet they are often present in RPL, detected by the non-specific mixed lymphocyte response assay. Blocking antibodies, animal model, you have the B cell deficient mice have normal pregnancy outcome, human A gamma globulin mix have successful pregnancies, pregnancy absence not predictive of subsequent outcome. Parental HLA sharing, if parents are antigenically similar, mother is less likely to develop blocking antibodies. But studies contradictory, some show increased sharing of HLA-B and HLA-BR loci, most show no association. Natural killer cells, the theory that is CD56 NK-like cells secrete a transforming growth factor beta-like substance crucial to the maintenance of pregnancy, which is present in the endometrium and the early gestational residua. But if it is not, then there are chances that it will be thrown out as a foreign body. Natural killer cells, murine models show activation of NK cells increases the rate of abortion. Depletion of NK cells has opposite effect. Human studies show no association of testing and successful pregnancy. T1, that is Th1 immunodystrophism. Aberrant or inappropriate Th1 stimulation may result in overproduction of cytokines that have a deleterious effect on the conceptus. Dichotomous CH1 versus CH2 cytokine profile associated with human pregnancy, loss and success. Now the environmental factors, ionizing radiation, organic solvents, alcohol, mercury, lead. Most important is caffeine. If it is consumed more than 300 milligrams per day, that's 3 to 5 cups of coffee per day. And cigarette smoking because of the nicotine, which causes the vasoconstriction. And alcohol, of course, where if more than 3 drinks in the week in the first trimester or more than 5 drinks in a week in the second trimester. Unknown association with pesticides, diagnostic x-rays, air travel, microwave ovens, diagnostic ultrasounds, electromagnetic fields, video display terminals, chocolate, drinking water, phytoestrogens, herbicides, hair dyes, nail polish, and saccharine, and also lipstick with the lead that is included in that. So more than 50% of the couples with RPL have no explanation despite extensive evaluation. Informative and sympathetic counseling appears to play an important role, telling them that pregnancy is a physiological change in the body and not a disease, and tender loving care, that TLC, would take you a long way, with 70% of the live birth rates reported in couples with unexplained RPL who undertake an untreated subsequent pregnancy, and they have a live birth rate of almost 70%. So how do you manage? On management, you are going to first see the history. Once the patient walks into your clinic, you are going to ask the history. The age is very important because with elderly patient more than 35 years, abnormal oocytes and therefore the abnormal embryo and therefore the RPL. Then you ask about the family history of either diabetes mellitus or history of hypothyroidism or thrombotic episodes in any of them or in the patient itself. Then on history of diabetes mellitus and on other histories like alcohol, caffeine, tuberculosis in India, very common. Then what is the pattern of the loss? Which trimester it was? And whether the FHs were present, whether it was painless or it was with pain and bleeding. Factors, toxins and drugs, which I told you. Known gynecological or obstetrical infection and APS, as I told you, could be the reasons that you have to find out. So, family history of RPL, previous diagnostic tests and treatments that they have done, general physical examination. I told you, you see the secondary sexual characters, whether you feel that there's a excess hairline on the upper lip, she's a PCO, there's history of diabetes mellitus. Then comes to the local examination, where there are signs and symptoms of any cervicitis, suggestive of endometritis, or whether there is any infective focus which you could think of for speculum examination. Then you will do for the investigations, you will do a saline sonography, but nowadays we don't do all this, we do a 2D, 3D ultrasonography with a sonohysterography. Luteal phase defects, endometrial biopsy, again it's questionable. Placental fish analysis, parental karyotypes, lupus anticoagulant, and the whole workup for antiphospholipid. This is a photo showing the example of PGD aneuploidy, which is done in elderly patients, where you have, with the age, the abnormal oocytes, the abnormal embryo, and therefore the PGD is done, and selection of the proper embryo is done, and the embryo transfer is done. So, tests will include the antiphospholipid antibody, IgG, IgM, platelet count, thrombophilia mutations, and functional assays, thyroid stimulating hormone. Other tests which are not important, I'm not going to talk, I'm going to skip this slide. For hereditary or acquired hemophilia, heparin, you are going to test. And of course, Dr. Uday will talk NLEM, aspirin and heparin, they do wonders. So this is also I'm going to skip because Uday is going to talk on this. For elevated homocystinemia, without hormosis history, you are going to give supplementation with folic acid, B6, B12. Heparin anticoagulation is considered only if this dietary changes, the dietary repairs what you are doing. If they don't act, then only your heparin is asked for in this particular condition. And that also we give in therapeutic doses. I think with this, I should end my talk. And the prognosis I'll just give. The prognosis is very good if the cause is found out and we go in the direction of the cause. But The problem with RPL is, the same cause might not be repeated the next time, and therefore RPL is a challenge which all of us have to take seriously, and take care of our patients and see to it that they have a lovely life birth with a nice healthy baby. Thank you so much.
Thank you, Bharti. You have exceptionally taken a lot of pains and a lot of research being done for that RPL presentation, because I remember RPL is a very vast topic and it encompasses the whole obstetric gynec, and we can sit here for next 3 hours discussing RPL, but I'm sure you have given wonderful justice and covered all those points. So we will come back to you soon. Thank you. And now we go to Uday Thanawala. He is going to speak on low molecular weight in RPL, and the mic is yours, Dr. Uday.
Thank you very much, Niranjan, and I'll just start Can you see me on this? Can you have do you have my screen on your thing?
Yes, we can see the screen.
Absolutely, so nice.
And you can hear me also.
Yeah.
Is it clear?
Yes. Very clear. Very clear. Please continue. Thank you.
Okay, so let's come to a little bit of practical things after the theory which we have heard about RPL, with that background which Bharti has given us. We just come to some clinical situations and how we are going to deal with it and how we are going to use heparin in it. So if you have a patient with previous 3 abortions, and all of them were first trimester abortions at 6 weeks and 11 weeks, and she comes and asks you, her first question to you is, what are my chances of having a normal child? And that is what you need to tell her once when a woman comes with multiple abortions. I can't seem to change my slide from here. Okay. So from the prognosis, from the history, the chances of having a repeat abortion, if the woman has had 1 spontaneous abortion, is about 15%. After 2 consecutive abortions, her chances of having a repeat abortion is around 25 to 30%. And after 3 consecutive abortions, the abortion rate goes up to 33 to 45%. So even after 3 abortions, the chances remain at 45% maximum, means there's a 55% chance that she will have a normal pregnancy, ongoing pregnancy. So you have to bring out the brighter side when a woman comes with you with RPL, because these women are highly stressed, they are very dejected, they are very morose. You have to lift up their model and say that no, even if you have had 3 previous abortions, there's a fair chance that you will have a good normal pregnancy, even if you don't see a doctor or don't get investigated. Now, it's not that we're not going to investigate her, but we have to at least tell her that there's light at the end of the tunnel. And for a woman who has had a live birth, even if she has multiple losses, the risk in the future for a pregnancy loss remains at around 30%. So, after investigations, contributing factor can be identified in 40 to 50% of these cases. Like Bharti told you, if you investigate these patients, when treated, the prognosis for successful pregnancy outcome is typically 80%. And even in couples where no underlying problem is found, the chances of a successful pregnancy can be in the range of 50 to 70%. So let's come to one clinical situation. We have a gravida phi who comes at 6 weeks of pregnancy. She's had 1 missed abortion at 9 weeks. She had a 2nd chemical pregnancy. The 3rd was an ectopic pregnancy for which a left salpingectomy was done. After that, she had undergone an HSG for secondary infertility, and the cavity was proven to be normal and the right tube was patent. She conceived spontaneously after that, but landed up with a missed abortion at 10 weeks. At that time, we did a karyotype, and the karyotype was normal. So now if we look back at this case and we see that does it fit into our definition of recurrent pregnancy loss? So technically we are saying it could be either 3 consecutive losses below 20 weeks, as I've been told you, or the American Society says 2 pregnancy losses. They are not consecutive, so it could be either primary or secondary, with one progressing to beyond 20 weeks. but ectopics and biochemical pregnancies are not included. Now, if you see this, that means that this patient has technically only 2 spontaneous abortions. Okay, so anyway, we take it as a case of RPL, and since anatomy, uterine anatomy has been proven to be normal, and karyotype of the last pregnancy was normal, we say let's do her thrombotic profile as Bharti said. So we screen for acquired thrombophilias as the antiphospholipid antibody syndrome, which is important. And of course, I have listed the inherited thrombophilias here, which will come to see whether we should really be doing it further or not. The classification criteria for antiphospholipid antibody syndrome, as Bharti said, is vascular thrombosis is one, and of course pregnancy morbidity, that is 3 or more unexplained congenital miscarriages, genetic, anatomical, hormonal causes excluded, 1 or more unexplained deaths of morphologically normal fetus at or after the 20th week of gestation, 1 or more premature births of a morphologically normal neonate at or before 34 weeks of gestation is what is considered as pregnancy morbidity in RPL. And the Sepporo's criteria, which was mentioned, is that 1 clinical criteria for vascular thrombosis and 1 immunological criteria, either the lupus anticoagulant or the anticardiolipin antibody, and that would define the term antiphospholipid antibody syndrome. It would be nice if Bharti, if you muted your camera, because it's causing a little bit of disturbance. So basically, screening guidelines of 2017 recommend for women with RPL, screening is recommended for antiphospholipid antibodies after 2 pregnancy losses, and screening for antiglobulin phospholipid can be considered after 2 pregnancy losses, that is beta-2 glycoprotein can be done also. So in this case, we investigated her, and the anticardiolipin antibody IgG and IgM came negative. The lupus DRVV came positive, and the beta-2 glycoprotein came in the normal range. So we labeled as a case of antiphospholipid antibody syndrome, and we decided that she needs treatment. So in women with recurrent pregnancy losses associated with antiphospholipid antibody, the live birth rate in pregnancy when no pharmacological intervention has been reported is to be as low as 10%. Because if you don't treat this woman, in that case, the pregnancy loss will be very high. So it's basically, once we've proven that the cases of antiphospholipid antibody syndrome, it is better that we treat them rather than to just leave them alone. And the treatment in OAPS, now OAPS is obstetrical antiphospholipid antibody syndrome, means that is a woman who has got only obstetric pregnancy complications and not a vascular thrombosis. A very good maternal and fetal outcome is noted in women with obstetric APPS when they were treated, and the treatment basically is aspirin and heparin, as has been told to you. We come to another situation where we have a gravida 4 para 2 abortion 1 who comes at 6 weeks of gestation. The first is a missed abortion at 8 weeks or at 10 weeks. Second, a preterm birth at 30 weeks, severe IUGR and PIH in that pregnancy. The third, she had an IUFD at 28 weeks because of abruptio placenta. And again, we suspected that that could be a case of APLA. We investigated her, and here we got an anti-beta-2 glycoprotein to be positive, and the patient was started on aspirin and heparin. So basically, when you talk about treatment, the treatment in a lot of meta-analysis has been shown that basically low-dose aspirin plus heparin prevents further miscarriages, and this treatment combination significantly reduces the miscarriage rate by 54%. That is aspirin plus unfractionated heparin compared with aspirin alone. So when do you start anticoagulation therapy? Start aspirin and prophylactic dose of low molecules of heparin is that the drug, apart from its anticoagulant action, seems to promote successful implantation in early pregnancy. The explanation for this may be that heparin binds APL and thus prevents APL producing the physiological coverage of trophoblastic cells with potent anticoagulant protein like NX5, but this remains to be established. So heparin has a role in early pregnancy also. So it is best to start aspirin and heparin as soon as pregnancy is confirmed by a pregnancy test. When we come to heparin, what is the prophylactic dose? Now, a prophylactic dose is used in the obstetric antiphospholipid antibody syndrome, where the patient has not had any vascular complications. So, a low molecular weight heparin is started, and enoxaparin at the dose of 40 milligram per day subcutaneous, and deltaparin at the dose of 5000 IU per day subcutaneous. If you want to use unfractionated heparin, and it's perfectly alright to use that, as we will see in the other studies, unfractionated heparin, we generally start in the dose of 5000 international unit twice daily in first trimester, 7500 international unit twice daily in second trimester, and 10,000 units twice daily in the third trimester. That is what is suggested when you use unfractionated heparin and not a low molecular weight heparin. If you use a full anticoagulation, if you require full anticoagulation, that is in women who have had a history of DVD or a vascular thrombotic event and has proven to be RPL and is pregnant, then you use enoxaparin, Then you use enoxaparin 1 milligram per kilogram subcutaneous every 12 hours and deltaparin 2000 or deltaparin 2000 international units per kilogram subcutaneous daily. Unfractionated heparin, if you want to use in these cases, you have a subcutaneous doses, 12 or 8-hour interval, so that to obtain a PPT 2 times the patient's normal prothrombin time. So the prothrombin time has to be taken, and you have to achieve 2 times prothrombin time than the normal, and this is to be checked every 3 to 5 hours of injection. So that is why unfractionated heparin is not really seen as a very so when you talk about low molecular weight heparin versus unfractionated heparin, there are studies which show that more or less the results are more or less the same. There were no bleeding episodes, there was no thrombosis, no other problem. So basically both are equally effective. But because of the problem with unfractionated heparin, more monitoring which is required, people have switched over to low molecular weight heparin. What are side effects of heparin? One of the side effects is osteopenia, significant loss of bone mineral density in proximal femur and lumbar spine during extended use of unfractionated heparin. Remember, we will use this throughout pregnancy, so you have to be very careful. Recent studies evaluated the use of low molecular weight heparin for extended periods during pregnancy and found no greater loss of mineral density than seen in normal controls. So basically, low molecular weight heparin has less of problems with the bone, and giving calcium supplements 1000 to 1500 milligrams and vitamin D concomitantly with unfractionated heparin is advisable in pregnancy when you are giving heparin. We anyway give calcium supplements. The other side effect of heparin which we must know about is thrombocytopenia. There is an immediate type which can occur with heparin, which is reversible and does not require any discontinuation of therapy, and this occurs between 3 to 7 days of starting treatment with heparin. And you have another late onset immune type of thrombocytopenia which is severe and occurs 5 to 14 days later. So patients on unfractionated heparin, platelet counts on day 5 and then periodically during the first 2 weeks of therapy should be done. Whereas patients on low molecular weight heparin, you can just do it 1 or 2 weeks after initiation of treatment, and in general, after that, patients who are on low molecular weight heparin, we really do not require too much of monitoring of anything else. So low molecular weight heparin during pregnancy offers a number of advantages over unfractionated heparin. It is of equivalent efficacy, once daily dosing, lower risk of heparin-induced thrombocytopenia and osteoporosis, less intensive monitoring, and of course, unfractionated, now we offer it to women who really can't afford low molecular weight heparin. So basically, maintain a mid-interval. So when you are putting patients on heparin, how do you monitor? How is their response? We've talked about the unfractionated part where you do the activated prothrombin time, which you can do. So low molecular weight heparin on the other, unfractionated heparin, activated partial prothrombin can be used to monitor the intensity of anticoagulation. But low molecular weight heparin is a little more difficult to monitor the anticoagulant effect because they interact little with factor 2 and do not predictably prolong the APTT. So basically, if you want to monitor low molecular weight heparin, you have to basically do anti-factor 10A activity, which is not easy. So in general, it doesn't require too much of monitoring. So the next question is, when do we stop heparin and aspirin? Now, this is important because effectively stopping low molecular weight heparin 24 hours before planned induction of labor is important. Electively stopping prophylactic dose of low molecular weight heparin or unfractionated heparin at about 38 weeks of gestation can be considered to avoid spontaneous labor, or switching therapeutic unfractionated heparin at about 36 weeks with instructions to discontinue at the earliest stages of labor. Means you switch over from low molecular weight heparin to unfractionated heparin at 36 weeks of gestation, and tell the woman if she goes into labor or has any signs of labor, she should not take the next dose of unfractionated heparin. The additional advantage to use unfractionated heparin include monitoring the prothrombin time measurement, which is easy, and the ability to completely reverse the heparin effect with protamine sulfate if major bleeding occurs. Low molecular weight heparins are only partially reversible. So, when the patient is on low molecular weight heparin, you have to plan when we need to stop it. The American Society of Regional Anesthesia guideline says that if your patient is on low molecular weight heparin, you should stop heparin 10 to 12 hours after the last prophylactic dose of low molecular weight heparin and at least 24 hours after the last therapeutic dose. Means if you are planning to give epidural or any anesthesia, there should have been no dose received between at least 12 hours and 24 hours. Okay. So in obstetric APLS, what about postpartum? How long do you continue if it's only an obstetrics antiphospholipid antibody syndrome? So prophylactic dosing, unfractionated heparin or low molecular weight heparin can be given subcutaneously starting at about 6 hours postpartum once hemostasis is confirmed. After the woman is delivered, you can start heparin around 6 to 12 hours after delivery has occurred and you've made sure there is no PPH or there is no other bleeding problem. And a therapeutic coagulation for women who were on therapeutic doses of anticoagulation because of any thrombotic event which they've had, intravenous heparin should be started without a bolus to minimize bleeding risk with APDT measured 12 hours later, or initial prophylactic dose of low molecular weight heparin almost 12 hours after postpartum, after which therapeutic dosing can be reduced from postpartum day number 1. So this is all what we should know about starting heparin again. Now once she is delivered, can we use warfarin? Yes, warfarin appears in minute amounts in breast milk and has not been associated by any adverse effects of the newborn. So warfarin can be started on women who are requiring anticoagulation. But heparin should be continued during the initial days of warfarin therapy until the INR is at a therapeutic level, that is 2 to 3 times for 24 hours. And postpartum anticoagulation should be continued at least for 6 to 12 weeks. Now, let us talk about some cases where you have an APLA negative and there is no history of vascular thrombosis. So would you screen these patients for inherited thrombophilia, what was talked about, like factor V Leiden, protein C, protein S, antithrombin deficiency, etc., etc.? At present, no prospective studies of association with recurrent pregnancy loss. No randomized trials of thromboprophylaxis have been proven, and it is unlikely that inherent thrombophilia can cause recurrent pregnancy loss in the first trimester. According to the update, it is insufficient evidence to screen for hereditary thrombophilias based on previous adverse pregnancy outcomes, whether the IUGR, stillbirth, abruptsia, or pregnancy loss, alone in the evidence of additional risks of thrombosis. Unless she has history of DVT, there is no point in screening these patients for hereditary thrombophilias. Now, this is important because we must remember that all this costs money, and many people are just advising these investigations without really helping our patients, So it is better that we avoid doing unnecessary investigations. So basically, the ASHRIC guidelines 2017 also say that for women with RPL, screening is not recommended, or women with additional risk factors for thrombophilia. Sorry for that. I was just getting a message. My internet connection is unstable. Is it okay? Am I clear, or is something going wrong?
Oh, it's fine. Continue.
Okay. So basically, Society of Fetal Medicine says in the 5 things this physician should question is: don't do inherited thrombophilia evaluation for women with histories of pregnancy loss, intrauterine growth restriction, and preeclampsia. Okay. So basically, when you talk of inherited thrombophilia, what is their importance? A meta-analysis of retrospective studies has reported a strong association between second trimester miscarriage and inherited thrombophilia, factor V latent, factor II prothrombin gene, and proteinase deficiency. So women with second trimester miscarriage can be screened for inherited thrombophilia, including factor V latent and factor II and gene mutation and protein S. Now, protein C and protein S, you have to be careful when you test in pregnancy, because protein S is a cofactor of protein C, which lowers the activated factors 8 and 5. So pregnancy reduces the levels of protein S to 40 to 50% of normal levels. So the second trimester fall in Phe protein S is physiological pregnancy adaptation, and one cannot correlate this. So women with a thromboembolic event appearing the first time during pregnancy should have investigation for protein S pregnancy deficiency delayed until postpartum period. So basically, it may not be a great idea to test for protein C and protein S during pregnancy. And if you are testing, does aspirin and heparin even work? That the heparin therapy during pregnancy may improve the live birth weight of women with second trimester miscarriage associated with inherited thrombophilia, but there is insufficient evidence to evaluate the effect of heparin in pregnancy to prevent miscarriage in women with recurrent first trimester miscarriage. So basically, second trimester miscarriages, multiple, you have done inherited thrombophilia, something is positive, yes, heparin and aspirin may help you. But otherwise, inherent thrombophilia really don't have too much of a role to play. So if you have no conclusive positive test, like if everything is normal, all your tests come normal in a woman with recurrent pregnancy loss, do you treat her empirically? We have got studies here, which the SPIN study and the ARAC study, which say that there is no benefit in treating these patients with low dose aspirin or molecular weight heparin in case you have an unexplained case of RPL. So please remember that. What is more important is tender loving care and important of a one-stop clinic. Now these patients, it's important to give them empathy and emotional support. We should not shrug them away that this woman will come to you repeatedly. Slight bleeding, she'll call you up. Oh, I saw a spot of blood. What do I do? So her reassurance is very important. Of course, other subjective therapies like progesterone and maybe HCG will help. But at the same time, it may not, at every visit, show her the heartbeats. She'll be happy about it, and you have to make sure that you show her that you care, you give her enough care and enough support, and maybe that also, a tender loving care also has a very important role in unexplained recurrent pregnancy loss. So women with unexplained recurrent pregnancy loss have an excellent prognosis for future pregnancy outcome without pharmacological intervention if offered supportive care alone in the center, in the care of a dedicated early pregnancy assessment unit. This is one of the recommendations from the Green Top guidelines. Now, I think let us put all this knowledge in a little bit of a clinical perspective. So here it is. If you have been really sleeping through the lecture, now wake up. This is very interesting. And tell me the answers to this. After 8 consecutive miscarriages, a patient has a recurrent miscarriage screening. All blood tests are returned normal. She inquires about what medication to use in subsequent pregnancy. So the question is, in the following scenarios, when is heparin an appropriate therapeutic option? We are talking about heparin. So are you going to give this woman heparin?
No.
from what we have just said? No.
No.
According to this, we are not going to give it heparin because we have not found any cause. Nothing has turned positive. Patient B presents with a positive pregnancy test. She's had 2 DVTs in the past 7 years. So in this case, is heparin recommended? Yes?
Yes.
Yes,
no.
therapeutic.
She's
Therapeutic.
is she going to be put on heparin?
Yes.
Yes.
Therapeutic.
Yes. So we are going to put her on therapeutic doses of heparin.
Heparin.
Patient C is pregnant for the first time. Her sister is positive for APS and has had aspirin and heparin treatment after 4 pregnancy losses. Her sister is APS positive. She's had pro-pregnancy losses and a successful pregnancy after heparin and aspirin. So should she be put on aspirin and heparin?
No. No.
Only then, not otherwise.
No.
No. So we don't put her on heparin. We don't use heparin in this case. Patient D is diagnosed with APS and has 3 miscarriages. She is now 5.3 weeks pregnant. Would you put this patient on heparin?
Yes.
Aspirin plus heparin.
Aspirin plus heparin. Barabar.
Okay, so we will use heparin in this case. A 36-year-old multipara presents in early labor at 5 a.m. She is a case of APLA with venous thrombotic thrombosis and is now 28 weeks of pregnancy. She is on therapeutic doses of low molecular weight heparin and her last dose was at 8 p.m. last evening. Her current gestation is 35 weeks and her previous delivery was vaginal and she was induced for post-maturity. Cervix is effaced but not dilated. She demands an epidural. So what are you going to do? You're going to check the anti-10A levels and if normal she can have an epidural, or you're going to advise that it is fine, she can have it after 8 a.m. if she labors. Advise her that it would not be safe to insert an epidural until 24 hours after the last dose, so as not to inject any more, and admit her and observe her. You will admit her and change to unfractionated heparin, or you will advise her to have no further heparin till after delivery to reduce the risk of bleeding. First,
False. No.
false. What would you say?
Otherwise, you have to have no further heparin.
Can you see the slides?
Yes, yes.
Hello?
Yeah, we can see the slides.
Okay. But I can't see some pictures. Okay. So, would you advise her to have it after 8 a.m. if she labors?
No.
Yes.
No.
After 10 to 12 hours, she can have.
No, she's on. She's in labor now.
She's on therapeutic dose. So ideally,
Bindu, you are very smart.
No.
She's on therapeutic dose because she is a case of venous thrombosis. So technically you will wait for 24 hours.
Yeah.
Okay.
You can't give her at 8 a.m. if she wants epidural. Of course, this is true that you will tell her after 24 hours and we will admit her and observe her if she goes into labor. Admit her and change to unfractionated heparin. Yes, you can take that option. This is false because you can't advise her not to have heparin until after she delivers because she may take a long time to deliver and she's a case of venous thrombosis, so she again may throw an embolus or have some problem. So thank you all very much. I think I have pushed in the ball for the panel discussion to come anyways. So more to Niranjan when I hand it over to you, but I must thank you to bring this very interesting webinar to us. Thank you all very much.
Thank you so much, Uday. You have done a wonderful job and really a lot of efforts you have put in on the slides. And we had a question answer session also at the end of this wonderful presentation. So now we would go to the question answer session and I start with Dr. Rahul Vani. Dr. Rahul, what are the various treatment options and pregnancy outcome in women with idiopathic recurrent miscarriages?
As in both the presentations, both Dr. Bharti More and Dr. Uday Thanawala said, idiopathic recurrent pregnancy loss, we would define it as idiopathic only after we have done all the investigations and we don't find any cause. So first thing before labeling, we need to investigate properly and find out and see that there is no etiology behind the pregnancy loss. And most of the times, without any treatment, these patients will have a good outcome. In 50 to 70% of the patients will have good outcome. So having said that, there have been various things which have been tried, like enoxaparin has been tried, aspirin has been tried, folic acid has been tried, prednisolone has been tried. So aspirin, as we all know, it is an antiplatelet activity and it balances that prostacyclin and thromboxane balance. So if you have to try, I think just aspirin, which is cost effective and the no side effects, that would be fine rather than trying any other else. Any other thing. They say that prednisolone will help with anti-inflammatory action. They also say that progesterone, micronized progesterone used vaginally will also has in some studies have shown that it reduces pregnancy losses in idiopathic. But there are insufficient evidences and they are inconclusive. So I would rather go only with aspirin.
Okay, fine. Yeah, there are various studies also. Daya and Goldstein et al. Also has demonstrated that progesterone supplementation significantly improves the pregnancy outcome in women with this idiopathic recurrent miscarriages. There is a very big study done by TOG also, where treatment option and pregnancy outcome in women with idiopathic recurrent miscarriages was also done. So thank you, Dr. Rahul, for that wonderful answer. Uday, you just had a very elaborative RPL and low molecular weight presentation, but you know our viewers have joined also later on. So I would request you that how effective low molecular weight heparin is helpful in improving the live birth rate in patients with unexplained recurrent pregnancy loss and having 2 or more consecutive pregnancy losses.
Well, it's like this. Let me tell you, we started using heparin in the early 90s when we had no answers to recurrent pregnancy loss. And that time I once called up, we were discussing in one of the forums with Dr. Hema Devakar, and she said, why don't you just try 2,500 units of unfractionated heparin once a day in your patients. Now, that is what I started doing so long back with patients who had come with recurrent losses. At that time, we didn't have any thrombotic panels to be done or anything to be investigated, because those things were simply not available and they were very expensive for our patients at that point of time. So believe me, it used to really work. So in spite of all the evidence which is there that an unexplained pregnancy loss, nothing may have heparin or aspirin. It may have the same effect or no effect, but technically, even I think the act of calling the patient and maybe giving her that one injection every day or telling her that, because 2,500 in the international units was no dose at all. Even the dose recommended is 5,000, but somehow we used to work and we used to compare notes every year and she would say, oh yes, it works. So that is what it is. We really don't know how much unit has to play, but there are definitely studies which say that even if you have patient with multiple losses with no cause found, maybe aspirin and heparin will help. But if you go by the book, they say that no, it has got no therapeutic action. Whatever you have to add, Niranjan, to that.
Okay, thank you. I remember also we used to have the BOH OPD in Sion Hospital, and we used to get this 3 to 4 or 6 abortions. And in those days, there were a lot of patients where we used to do torch titers, if you recollect, in 90s.
Yeah.
And yeah, IgG and IgM. But now I think it is totally irrelevant, and we used to do that. But obviously, those days aspirin was also given for there was one FLAST study which was there by Dr. Usha Krishna, if you recollect. And that was also conducted by Dr. P.K. Shah, but that was for preeclampsia, and there were some patients with recurrent pregnancy losses and preeclampsia also developing. But I'm sure now there are various studies which have come to conclusion that Obviously, aspirin is there to stay, and low molecular weight heparin also can be tried out in this unexplained recurrent pregnancy loss. Thank you so much. Now I come to Dr. Bindu. Welcome, madam. There's one question for you. Should thromboprophylaxis be given throughout pregnancy in women with previous history of recurrent miscarriages of unknown etiology? What is your take on that?
Yeah, most of the times, unknown etiology, we have to actually investigate the patient why the pregnancy losses happen. And we are able to find out the cause in around 40 to 50%. Rest 50% is unknown etiology. In this, like Dr. Thanawala was talking, the tender loving care actually helps a lot. But then we have to have like this aspirin, low dose aspirin, definitely studies have been there. They improve the pregnancy rates, and small studies for using low molecular weight heparin. There are certain studies which show that the combination of low molecular weight and aspirin have improved the pregnancy rate in women with recurrent miscarriages of unknown etiology. But large meta-analysis say that they are of not much significance or use. But definitely women who have congenital or acquired thrombophilia, where there is a history of venous thrombosis, or they have pregnancy losses before the 34th week of pregnancy, or any untoward obstetric event, and where we investigate them for thrombophilic syndrome, they definitely have to be given this low molecular weight heparin. But practically said, most of the times with recurrent miscarriages, we adapt to the way of low dose like aspirin and low molecular weight heparin. Definitely in our practices, we have shown that the improvement in pregnancy rates have definitely been there, and take home baby rate is there.
Okay, there are many questions which are also coming, but we will get back to them. What are the doses which are there? Obviously, this has been completed taken into the lecture also, but there are viewers who have just marathonly joined us, and they are very excited, and they want to know what are the doses which you will give in this. So can you please elaborate on that?
So, if considering the empirical thing which I talked about now, that is 40 mg or 0.4 ml of enoxaparin will help. And if a heritable thrombophilic syndrome is there, then definitely we have to go for the therapeutic dose, that is 1 mg per kg body weight subcutaneously of low dose heparin BD in 2 divided doses. And that has to be continued throughout the pregnancy, and it is stopped just if you have an elective induction of labor, it is stopped 24 hours before the induction of labor. Or there are things like you can convert, if you have, the patient is going into labor, we can convert it to unfractionated heparin in the last few weeks of pregnancy, so that the effect doesn't last long and we don't have postpartum complications later on. Okay. And if you are planning a cesarean section in those patients, with the empirical dose, we can stop it 12 hours before. And with the therapeutic dose, we can stop 24 hours before the cesarean section.
So I think all this has been a very important role in our modern obstetrics, and studies have suggested that women treated with low molecular weight heparin have significantly lower abortion rates. And there are similar questions. Thank you, Dr. Bindu, on that take. Now, Dr. Bharti, I want to know from you. You gave a wonderful lecture on RPL, described all the causes, how to go about it very briefly. But now I want to ask you, what is natural micronized progesterone especially beneficial in women who have a history of bleeding and they have 3 miscarriages? What is your opinion on this issue of micronized progesterone?
Yeah, thanks, Niranjan. Micronized progesterone, it is seen that it modulates the contractility of the fallopian tubes and facilitates the whole activity of the embryo coming from the fallopian tubes into the myometrium and the implantation process. So progesterone definitely plays a very important role in the embryo to be implanted in the endometrium, and therefore progesterone supplementation, especially in ART pregnancies, where because of the gonadotropin use, large doses of agonist and antagonist use, you have a very low levels of progesterone, which is the effect of the agonist. Especially in these cases, you have to supplement them with progesterone, and they have a, they keep the endometrium and the physics of the tubal and the myometrium is such maintained that they help the implantation of the pregnancy. So
So implantation, maintenance of pregnancy is also very important.
Very important.
And we have that shift, the corpus luteal shift which occurs.
Yeah.
So you recommend when after 7-8 weeks you start, or you recommend in the second trimester?
You start initially we give HCG, and then 7-8 weeks we start progesterone. That should be given up to 12 weeks, 12 to 14 weeks when it goes to the placenta. The supplies go to the placenta when the placenta takes over. So till then you have to give progesterone, 400 milligram VD. You can give them either oral, but vaginal progesterone are supposed to be best because the absorption is good.
Nowadays, there is no difference between oral and vaginal. I think people have accepted, our patients have accepted quite nicely that vaginal micronized progesterone natural would be a better option than oral, because then you eliminate the
First bypass.
the first pass effect, and that is
bioavailability is much better.
Yes. So there are a lot of questions, but I will go back to now Dr. Uday. Uday, there is one question by Dr. Deepti Srivastava. Now she has asked a very interesting question. Can aspirin and low molecular weight heparin induce bleeding anytime in pregnancy?
No, technically no, they will not induce bleeding. It's just a scare which we have, and if you think they're going to induce bleeding, we'll do the prothrombin time and INR and see what it is. But technically, it's very rare that aspirin and heparin are responsible for bleeding in pregnancy.
Now, Dr. Rupakshi has also asked you one question. What is the role of Bhar Globe as it is used by every OBGYN specialist these days in RPL cases?
Not me. I mean, it's not that I don't know how it is, because it is not. See, immunoglobulin has no definite role in recurrent pregnancy loss. Now, we had a chat with Dr. Howard Karp, and we had a lecture with him, and I attended one conference last year in UK, where he very clearly said they reserve immunoglobulin for patients who have had sort of 8-9 pregnancy losses, nothing else is found, and after 7 or 8 losses, then they advise immunoglobulin. I have no experience of using immunoglobulin, but Dr. Hema Divakar has used it in, I think, 2 cases, and you have to give immunoglobulin, one before the woman becomes pregnant, and second is during the pregnancy, after the first trimester of pregnancy, 2 doses. But this immunoglobulin is not Bharglobe. This immunoglobulin is the one which the people use in ICU. The one with the drip, the one which you give as a drip, the medical people use in ICU, it is that immunoglobulin. It's about 12 or 13,000 expensive thing. So I don't have much experience, but the immunoglobulin which is mentioned in the literature is that immunoglobulin. Now, I have been asking Bharat Serum, you give me what this Bharglobe is. They say, no, it's immunoglobulin. But nobody has still now defined what immunoglobulin it is. I've got nothing against Bharglobe. I've got nothing against Bharat Serum. Please mind it. They're great friends of mine. But I am not clear about Bharglobe, about how useful it is going to be, whether it is just what actually it contains, whether it is the actual immunoglobulin is given, I think, IV, and the medical people use it. One can use it, and it is recommended only for cases where there have been multiple abortions or multiple pregnancies and no cause, and your aspirin and heparin has not worked, because aspirin and heparin will work in 70% of the cases of APL. But if aspirin and heparin has not worked and you've got nothing else to offer a woman, you've ruled out all other causes, then you may think of, thinking of giving immunoglobulin. But the immunoglobulin which people talk about in literature is the immunoglobulin which the medical people use. It's not the regular. According to me, I may be wrong, I may stand corrected, because I really don't have much clarity about that.
That's fine. That's fine, Uday. We continue with our presentation and of the question answer session. Dr. Rahul Vani, what treatment do you suggest for APS positive women, and when to commence the treatment, and what is the dose you prescribe?
The APS, usually what happens is APS is abnormal antibodies which causes coagulation, and it says that the blood flow to the fetus is not established, and that causes miscarriage. And to really call a patient to be APS positive, you need at least 2 readings 6 weeks apart, and the titers have to be medium or high. Just low titers or just weakly positive is not considered as APS positive. If you have a patient with APS positive, then this combination of aspirin and heparin really works. This is one thing which is well established, that antiphospholipid syndrome, this combination of treatment of aspirin and heparin works. They say at almost 7. If you use only aspirin, 40% live pregnancy rates. If you use a combination of aspirin plus heparin, you get almost 70% live pregnancy rates. So there have been other meta-analysis also, which have showed that if you use a combination of heparin and this aspirin, then there is a 54% increase in live pregnancy rates. And the same meta-analysis also says that heparin might play just a placebo role, and the addition of heparin does not increase significantly. So there are controversial remarks, but I think aspirin and heparin has worked quite well in antiphospholipid syndrome.
Okay, thank you, Dr. Rahul, for that enlightenment. Dr. Bindu, I come back to you now.
Yes, sir.
Can you clarify on low molecular weight heparin used in women with inherited thrombophilia?
Okay. So in inherited thrombophilia, we investigate. We do not investigate routinely in patients with like what you say pregnancy losses. It is usually considered those who are having second trimester losses. They can be investigated for inherited thrombophilia, especially the factor V lead-in mutation and prothrombin gene can be investigated. And also the other things, as Dr. Thanawala was telling, the protein C and protein S deficiency, they are naturally low in pregnancy. So you cannot, if you go to investigate in pregnancy, they will definitely appear low. So these inherited thrombophilia causing pregnancy losses, especially the second trimester, then maybe you have to investigate before pregnancy. Okay. So this like those who are not having any obstetrical complications, ideally there is no role of low molecular weight heparin. In women with inherited thrombophilias and like untoward obstetrical events before the like in the late third trimester or in the second trimester, they can be put on either unfractionated heparin or low molecular weight heparin. So the RCOG guidelines, they say that this like especially with homozygous mutation of factor V lead-in and the prothrombin genetic resistance, these women can be put on therapeutic doses of low molecular weight heparin, that is 1 mg per kg body weight subcutaneously in 12 early or in 2 divided doses. So definitely there is a benefit of using low molecular heparin in inherited thrombophilia, but documented second trimester losses or untoward events in the late trimester should be there. Just like empirical use of low molecular weight heparin in women like who do not have pregnancy losses and just thrombophilia is not suggested.
Okay, and I would like to add here Dr. Laura Ormachet from London. She has also had a wonderful study on management of inherited thrombophilia in pregnancy, and this was done in July 2016, where basically a lot of potential benefit from low molecular weight heparin was found in such cases. And thank you so much, Dr. Bindu, for giving us that message.
If I may just add, I would like the views of any of our panelists who have been using this Bhargov, or any of the viewers also, if they've used and they've had some experience with it, if you can know if somebody has been using Bhargov and had results with it.
Sir, we are not supposed to take any drugs named by their trade as per
the question you asked me about Bhargov.
Yeah, but since now we have already discussed that, so I think we should move on now because because they got other questions which are lined up, and there are many of them.
So one question was when to start those aspirin and low molecular weight heparin. So now the recent study says you should start aspirin pre-conception and low molecular weight heparin as soon as the pregnancy test is positive, not wait for the fetal heart activity. So that is one I think missed out. So that is
okay, thank you. The idea is that we have to give a clear-cut message about what they have to deal with patients with recurrent pregnancy loss, with thrombophilia, with unexplained recurrent pregnancy loss, especially happening related to this genetic causes also. So, Dr. Bharti, you have a wonderful explanation been given on recurrent pregnancy loss, but there are our new viewers who have joined. I think more than 600 members have already joined and logged in. So I'm very happy about that they are hearing Navi Mumbai, all doyens who are with us. Madam, I want you to tell us briefly the diagnosis, what you recommend for RPL. What are the tests which you will be able to diagnose? Okay, uterine factor, antiphospholipid, endocrine, or genetic or environmental, and just give us a small gist so that people can understand that how they can proceed with this diagnosis after your wonderful lecture we have heard, madam.
Yeah, so thanks Niranjan for that. Once the diagnosis of RPL has been done and you know that the patient has recurrent abortions, there is an array of investigations which we should do. You have uterine factors, you can do a 3D ultrasonography with a sonography. HSG also can be done, and hysteroscopy is the best thing to find out what are the causes. Hysteroscopy is good because at the same sitting with the consent taken, you can do the resection of the septum. Submucosal myomas and polyps can be resected, and adhesive also can be done. Antiphospholipid syndrome, if you think, like if you have the diagnosis confirmed, as rightly said, with one clinical and one laboratory diagnosis 6 weeks apart, with the ACL and the lupus anticoagulant and the anti-beta-2 GT1 positive, you give heparin and aspirin, which now Dr. Rahul Vani said, preconceptual start aspirin, and UPT positive you start heparin. If there's an endocrine abnormality, you see PCOS is rising in today's practice. So in that case, you can give where the glucose intolerance is seen. Here you can give metformin, which will give good glucose control. And if it is hypothyroidism, you see that TSH levels are raised more than 2.5, then levothyroxine should be given. If there's hyperprolactinemia, then you have to give bromocriptine. As I told you, in the uncontrolled diabetes mellitus with fasting glucose or raised HbA1c, you can give lifestyle management, weight loss, nutritional control, and metformin, and of course insulin in selected cases. Genetic causes, if you feel that it is early first trimester abortion, where karyotyping of the product of conception and parental karyotyping has to be done. Depending on the findings, you give genetic counseling, and for this, it is better you go for a pre-implantation genetic diagnosis and you do selection of the embryos and the embryo transfer is done. Or you have to do donor gametes, either the cases, you take donor oocytes if there's a maternal problem, or you take donor sperm. Especially if there's a balanced translocation which is diagnosed. Environmental factors, as you see in today's world, we are facing many people working in the IT sector, women are seen smoking, so drug abuse is seen, and alcohol intake and caffeine intake, so you have to see and tell them that they have to come down with the smoking, they have to stop alcohol, especially if it is more than 3 drinks per week or more than 5 drinks per week, they have to come down, and caffeine intake, there are girls people, especially the IT sector again, they just take 3 to 5 cups of coffee per day, which is going to hamper their pregnancy.
Yeah. Yeah. Anything else? Dr. Bharti, anything else? Can you hear me? You have unmuted. Bharti, please unmute. Please unmute.
Doctor, you're muted.
Yeah, can you hear?
Yeah.
Yeah, so psychological support is very important because unexplained accounts for almost 40 to 50%, tender loving care, and progesterone supplementation has been told before. There's infection, antibiotic, proper antibiotic treatment, and infertility DNA fragmentation test, especially now you see couples coming in.
Fine. Thank you so much.
Thank you.
Dr. Bharti wonderfully summarized all of your whole lecture in a way of how to diagnose and what are the small bits which you are given about the management. Dr. Uday, can I ask you a question on a woman who is presenting with already a bleeding PV, threatened miscarriage? Now we are using naturalized micronized progesterone. So will it help her when she's bleeding that time?
Can you just repeat the question? I couldn't get it.
Yeah, if you have a woman who is already pregnant and she has got threatened miscarriage, I mean she's bleeding, she has got bleeding and she has already previous history of 2 miscarriages. Now she has come to you. So what is your take on using micronized progesterone? Will it help to reduce any further abortion in this pregnancy?
Yes, definitely we'll give a micronized progesterone. We can give oral digesterone also.
Very good.
Molecules. Progesterone molecule will be important in supporting her pregnancy, especially if she is bleeding. And another thing which I do is also I give them HCG 5000 international units once a week till they reach the second trimester.
I think that's what we have been taught, that till every weekly we can give them HCGs also, and that will surely help, and that will be an added effect to do with this. Thank you, Dr. Uday. Rahul, what is the effectiveness of using natural micronized progesterone in women undergoing ART? Because in IVF also a lot of patients are coming, we have recurrent pregnancy loss, they have undergone IUI, they have got failed IUI, failed IVF, and then they come back. Any one of you who is doing ART can also answer this question, no problem.
So with ART, what happens is because of the ovarian hyperstimulation and use of GnRH analogs, and there is a change in the hormonal milieu, and there is a disorderly maturation of the oocytes and the endometrium. So this progesterone supplementation or luteal phase support definitely helps in maintaining the endometrium, helps in maintaining the pregnancy and implantation of the pregnancy. So I think with ART it is quite important to supplement progesterones.
Okay, that was very important. Anybody would like to comment on his views about ART? Dr. Bharti?
You're absolutely right. We as all specialists would definitely give a lot of progesterone. And not stop it till 13-14 weeks.
Yeah. So it has been basically a lot of trials also have occurred on that issue, and enormous amount of progesterone is given in such cases of ART also.
Can I talk?
Yes, you can, sure.
Yeah, see, ART specialists, they of course give high doses of progesterone, but at times you see them using low dose prednisolone also, and aspirin is also used. So almost, the patient is loaded with a big list of drugs, and they continue it not only up to 14 weeks, but they continue it like till 24 to 30 weeks of pregnancy.
Okay. Now I want to say here that, we have not got only audience from India, but we have got audience from Nigeria, Lagos, Muscat, Oman, Yangon. Yangon is a place in Myanmar, and Cameroon. And also there is a place known as Loem. I don't know whether I'm spelling it right, but there are viewers in France also. So I think Navi Mumbai has gone international. And with a new international airport, which we will see in the next 2 years' time, things are going to change And especially there are many messages which are coming here. There's one message from Dr. Kanika Singh, and they are appreciating the video which was shown of Navi Mumbai and the skyscrapers, the Palm Beach, the beautiful, the railway stations which have been made, and the Sanpada, Juinagar, and obviously there is a Devai Patil Stadium. Thanks to Nandita Palshetkar and her family that we are having such a wonderful, and I'm sure in the next few months we will see all those matches also coming up there, and we will see you and meet you, all of you. So thank you so much. Thank you so much. So we come back to a few more questions before we end this session. And I think this is the longest session of RPL, going for more than 1.5 hours. So I want to ask you an open question to all. So low dose aspirin or low molecular weight heparin with oral micronized progesterone in recurrent early pregnancy loss. So does it improve at the end of the day, does it improve the live birth rate and lower the miscarriages? What is your take? Each one of you can just tell us. And also, what is the use of prednisolone? Can we add that also in such cases?
I would not add prednisone at all. Low molecular weight in heparin, if there is something or even unexplained infertility, yes, it would add. Progesterone, yes, for first 12 weeks one can give it. There is no harm in giving it. So that's what it is. But prednisolone, I would probably stay away from.
No, especially I've been doing ART.
Or something like
I've been working with ART people. You go for a 2 days observer course, and I've seen them using prednisolone, especially if she is a idiopathic recurrent miscarriage, where they use prednisolone 20 milligram per day along with progesterone for the first 12 weeks of gestation with aspirin 100 milligrams till 38 weeks of gestation. And of course, folic acid is also given. So definitely prednisolone has a role in idiopathic recurrent miscarriages.
I would like to stay away from prednisolone because definitely in my practice I have not used it in recurrent miscarriages. But of course, low dose aspirin goes a long way in giving a good take-home baby rate along with low molecular weight heparin. And progesterone supplementation, especially in the first trimester of pregnancy, and all the patient needs is a tender loving care with all these, like good counseling, that your pregnancy will go on smoothly. That plays a long way and improves because in spite of all these treatments, we all know that a patient has a good take-home baby rate of around 50 to 70%. But low dose aspirin and low molecular weight heparin I have used in many of the recurrent pregnancy losses, and I had a fantastic effect.
Yes, Rahul.
Yes, most of them have summarized it well. Prednisolone I don't use. I would not recommend it to be used. And then aspirin we can use in almost all of the patients. And heparin, as per the indications, if it is an antiphospholipid, definitely yes. And other cases would depend on the factors which are positive. That's it.
Okay. So wonderful to have you from here, and everyone is very happy to see you, Bharti, Uday Thanawala, especially Dr. Rahul, Bindu, and we are missing Mini, but I'm sure she is already there somewhere and hearing us, and obviously all the members of Navi Mumbai are very happy to be there, at least meeting all of us, and I'm really happy that today I came to Navi Mumbai and I could able to showcase how beautiful it is.
Mini has to get a video started. Mini is there in this thing.
Oh, okay.
Yeah, but she's unmuted and okay.
Okay, thank you. So
yeah, Mini is starting her video.
Yes. Hi, Mini. How are you?
Hello.
You are a silent observer, and it is very important that you have joined. You are the president. Thank you so much. And I think now it's your time to give the vote of thanks. So, President Navi Mumbai, please go ahead.
This has been absolutely wonderful Yeah, this has been an absolutely wonderful webinar. I'm sure it's going to have hours must get to my heart. And it has been absolutely fantastic. It's been fantastic. All the speakers have been so well, and the simple the messages that have been put across. Thank you so much, all of you, all the viewers, all the panelists, all the organizers, Dr. Nitin Chavan, thank you, and Bharat Serum, of course, the organizers. And we hope to have more such webinars in the future. I'm sure this has been, I think this is the way forward, which people can really attend all these programs rather than going to a place. It's very difficult, so this is a much, much more doable thing. Thank you so much for all the effort, and it's been wonderful.
Thank you, Mini, and thank you all of you. I liked especially your headphones. They are really nice, and the stacks of books. So you are spending your time reading books. That's your library.
That's your library.
So all of you, and Dr. Bharti, hats off to you. I could see that mask when you came, and I'm sure you might be busy whole day working with your patients, and I admire that even in the evening time you're consulting, and all of you, Uday especially, and Bindu and Rahul Vani, to spend that time with the great, our audience. Our audience of TOG webinar are very, very excited to see Navi Mumbai members, and we are very grateful and thankful to you, especially all the members who of Navi Mumbai who have joined, and all other members. I would also like to thank Trans Integra, Subbu, Session, and Anuja to be there with us, and it's the team effort, and obviously Bharat Serum, who have done a wonderful job of providing the platform to all of us to reach out to everyone. So I would like to end here.
Thank you, everybody.
I would like to end here with a slide, if I can get a slide to see and show you all. So it would be better. And there are 10 things which we are supposed to do today. And those 10 things are: number 1, I am fighting hard for the things I want most. Number 2, I am taking action now. And I am focusing on the next positive step. Number 4, I am proud to wear my truth. I want to be truthful and honest to me and my patients and my family members. I have a lot to smile about. This is the wonderful slide I want to share with you. Point number 5, I want to have a smile, a lot of smile, and that smile I want to give to everyone, and I hope everyone will be smiling and happy, especially in the stressful corona times. Number 6, I am making the best of it. I want to be the best, and I want to get the best of it. 7, I want to let go yesterday's stress. We want to live in the present, and we want to live for the future. Number 8, there is enough time today to do something I love. At least I want to do some hobby of mine, maybe singing, or maybe playing some instrument, or spending or reading, and that is enough time to something which I want to love, and I love that. Number 9, I am priceless in someone's eyes. Each one of you is priceless in somebody's eyes, and that is more important and focused to be. And 10, it's not too late. It's not too late. We are still there, and we are going to be there. So for today, Atma Jnan, Atma Vishwas, se Atma Nirbharta ki aur. That's where we go ahead and we begin. So I leave it here. We join again sometime in future, and it is a wonderful occasion that all of you being here. Shabba Khair, Shubh Ratri, फिर मिलेंगे डॉक्टर निरंजन चौहान के साथ. And thank you again, Uday, Bharti, Bindu, Mini, Rahul, and the whole team.
Thank you.
Namaste. Thank you very much.
Thank you.